In this brief didactic, I'm going to take you through the practical steps of implementing universal precautions for opioid prescribing in palliative care. In previous lectures, we've already talked about the importance of universal precautions, but this is just the how-to. So the goal of this session is to help you implement the universal opioid prescribing guidelines in clinic. And these slides may help you when you work in clinic, so should be kept as a resource. The first step is to be prepared to prescribe controlled substances. You want to ensure that you're registered for the Prescription Drug Monitoring Program, New Hampshire, and if you have a license in Vermont. But either way, you can check multiple states with either the Vermont or the New Hampshire Prescription Drug Monitoring Program. You should ensure you have a token or have downloaded the RSA Secure ID app, which you will need not only to log in remotely, as you may have already found out, but also to sign controlled substance orders. If you will potentially prescribe opioids, you need to see the person in person, unless the rules change by the time you get this lecture, for the first visit, unless you've seen them in the hospital, because that counts. Or if the rules change, you must have the video capacity by telehealth, at least for the first visit. At the present time in July 2022, in-person visits are required once yearly in New Hampshire and every 6 months in Vermont. So how do we implement universal precaution guidelines for prescribing opioids? This is a template that we use as a quick reference guide. Your initial action, hopefully within the first or second visit, you're going to, check the PDMP, complete the opioid risk tool assessment if not already done, calculate and document the morphine equivalent daily doses, complete the treatment agreement, which should be scanned into the medical record, and complete a urine drug screen. At every visit, you should check the PDMP before prescribing opioids and calculate and document your morphine equivalent daily dose. And so these are the criteria where we have developed based on what others have done in previous guidelines, whether someone is low or standard risk, moderate or high risk. Now, if someone has an opioid risk tool using the original document, not the revised, less than 4, and their morphine equivalent daily dose is less than 100, and you clinically assess that they are low risk through your interview, then you're going to see them monthly. That's with all patients that you're prescribing opioids. Random urine drug screen at least yearly. Pill count, that's a clinician discretion, but now that we've moved more to telehealth, that's really not happening like that. And consider naloxone. I say really based on comorbidities, I think that everyone should have nasal naloxone in their home. If you've clinically assessed that there might be a moderate risk, or their opioid risk tool is 4 to 7, or their morphine equivalent daily dose is greater than 100, which we know is more associated with some challenges in terms of adverse effects, then you're going to at least do your random drug screen every 6 months. Again, because we shifted mostly to telehealth during the pandemic, you may see that this has not been consistently done. You want to make sure you prescribe naloxone. You'll see this thing about RN visit clinician discretion. We do allow our RN to do visits, and this is if the patient is stable and you don't anticipate any changes, just say it's for a refill. She cannot do a billable RN visit via telehealth. It has to be in person. Now, if you have clinically assessed that this person is high risk or their opioid risk tool is greater than 8, then you're going to try to see them every 2 weeks until stable. You can think about an RN visit, but it's really on your own discretion. Thinking about urine drug screens every 3 months, and you're going to definitely prescribe opioids. Again, in terms of this pill count, it just depends on if you're seeing this person in person. So prior to your visit, you're going to review the Prescription Drug Monitoring Program, because you might be in for some surprises, or one that I recently did and saw that a patient was getting prescriptions every week from someone in Indiana. So this was news to me before the visit. And you'll start with a medication review. So if they're not being seen in person, you might not have the RN to room and do the medication review. Under your rooming tab, I choose medication review. I tend to do it every visit with my patients, unless they're really stable and we've said that there's been no changes. But you want to make sure you know what they're on, because you might think about prescribing a non-steroidal anti-inflammatory, and if you see that they're on steroids and an anticoagulant, you might think twice. Or if they're on an SSRI and you're thinking about starting a fentanyl patch, you may want to think that, is there more risk for serotonin syndrome because of the 3A4 CYP activity? So you want to make sure that you look at this. And you'll complete the opioid risk tool only on the first visit when you're prescribing. Now, if there is a score in the medical record and based on your interview it seems like it's inaccurate, you can redo it. So what is this opioid risk tool? Many of you may have used it in your previous settings. It's to predict which individuals may develop aberrant behavior when prescribed opioids for chronic pain. Lynn Webster developed the original tool back in 2005, and it was really only tested on about 200 people in his clinic. This is not the updated revised tool, which I'm going to show you on the next slide, but this is what we have in the medical record. The challenges with this tool, as you'll see, like if you had a history of pre-adolescent sexual abuse, if you were a female, you got a score of a 3. If you're a male, none. And again, for alcohol and illegal drugs, you got scored higher if you were a man versus a woman in terms of family history. But this is what we are using in our medical record. This is a better tool that was revalidated by Cheadle as part of a secondary study, and it really is used to predict which individuals are more likely to develop an opioid use disorder. It eliminated the pre-adolescent sexual abuse question. It unweighted the responses between male and female. And it really is a predictor of development of opioid use disorder with a sensitivity and specificity of 0.85. So if your score of 2 or lower, it's a lower risk for development of opioid use disorder, and greater than 3 is a higher risk. So anyway, I just want you to know about that. This is really the preferred tool, but unfortunately it's not in our medical record, and it probably won't be during your time in fellowship. So the first thing you want to do is make sure that opioid prescribing, if it's not across your top tabs, when you open up a note, you want to select it from the rarely used and make it a favorite so it will be on your toolbar, and you're going to click that. And this is what you'll see. You'll see this opioid prescribing thing comes up, and then what you're going to do is you're going to click on opioid prescribing, and what's going to happen is you will see it comes up with the PDMP query date and then the opioid risk tool. And when you ask the questions and you click on the answer, it will automatically score the question, and then these results are automatically scored and stored in the records. So you can see in this example, the person has a family history of alcohol use, a personal history of substance abuse. Again, we don't use the word abuse in our vernacular. We might use misuse, but this was the terminology when this tool was developed. It's automatically showing the person was between 16 and 45 and had a past history of depression. So ideally, this is done before the first opioid prescription or when the person comes into your clinic. And this is why right now there's making a big push to start doing it on the inpatient setting, because we don't want someone to be started on a certain type of opioid inpatient and then they come to us and we realize that this is challenging because they may be higher risk than we realized, and then it becomes a challenge to step it back. So when you introduce the tool, I'm going to tell you that for me, I'm finding out all these answers, except for the sexual abuse one, just by having a conversation with my patient. But until you can learn to incorporate that into your conversation, just the same as when you're learning the serious illness conversation, you might want to say, as part of managing your pain, we want to make sure that we do it in a safe, effective manner. As you're aware, there's problems with opioid use, and I will be using this tool to ask you some questions. And you can just tell them there's been relationships between family history, previous history of alcohol or drug use, or illnesses that may increase the risk that a person may develop problems with opioid use. Now, if they say, what if a patient asks what counts as family? It's any blood relative. I confirmed this with Peggy Compton, who is part of the Cheadle study and who's done a lot of work in this area. And it's basically mother, father, aunt, uncle, grandparents, children. And then abuse. And this is like, I usually word it as have you ever had, or has your family members ever had problems with alcohol use that interfered with their responsibilities? But if you wanted to have signs, it's like someone who's drinking more than 7 drinks a week or 3 drinks on occasion, or a man who has more than 14 drinks per week or more than 4 drinks on occasion. If someone is smoking a joint a few times a week, this may not be abusive versus someone who may be smoking a bong 10 times a day. If someone tells you that years ago they tried prescription drugs, that's very different than if someone tells you they got hooked on them or they were taken off of them for problematic use. And this would include benzodiazepines as well. What do you do about this pre-adolescent sexual abuse question, which again was taken off of the revised tool? So for men, you really don't have to ask it because it's a 0 score anyway. For women, it's challenging, and I try to give a warning shot. The following is a sensitive question. The reasons on the questionnaire is it may have some association with risks for developing misuse. If the woman doesn't want to answer, you can assume it's probably positive. And if the woman becomes distressed, then this is an opportunity to make a referral. Now, I'm going to be really honest with you. There have been times I've not asked the question, but that's usually because I've already gotten a sense what their risk is. And this is someone who has scored 0 on everything else. Even if I put 3 there, they're still going to be at standard risk, which is what the score is. Or someone who has scored high on everything else, they're still going to be high risk. And I have made that decision because I don't agree with us using this tool, but this is what we have. We have a better tool, it's just not in our system. So the last question focuses on psychological comorbidities. Remember, these are pre-existing conditions. Have you ever been diagnosed with attention deficit disorder, schizophrenia, or bipolar? When you ask about depression, someone says, I'm really depressed now, then you would ask, have you had depression before in your life? If they say no, I just became depressed when I learned about I have cancer, I would not score this as a positive. So these are just some tips for completing it, and hopefully if you do it in your first couple quarters, you will be doing it with a clinician to actually coach you. In the note template, you will see opioid management guidelines, and if it's not there, the smart phrase is .pc opioid. First thing is substance use history, and I will document pertinent things, past history of cocaine, current history of illicit fentanyl use, daily methamphetamine use. Therapeutic cannabis, we should always be asking our patients if they're using cannabis because we want to know. We want to know if they have a therapeutic cannabis card. Are they getting it at a dispensary versus off the street? If they're getting it off the street, we want to make sure that we counsel them about the fact that cannabis has been tainted with methamphetamine and fentanyl and to use caution. The date completed needs to go under your treatment agreement, your naloxone prescription, your urine drug screening. You're going to put your risk stratification, standard, moderate, high, because you have already done your clinical assessment, which is your interview, plus your opioid risk tool looking at their morphine equivalent daily dose. Is it okay for an early refill? This is really based on your assessment. So say this is someone with advancing cancer using hydromorphone 4 milligrams 3 times a day, and you prescribe hydromorphone 4 milligrams every 4 hours as needed, and you write a prescription for 90 tabs. And all of a sudden they start using more, maybe because their pain is increasing, maybe because their disease is progressing, but you decide this person is a low risk. You would put Yes. And this is more for the fact of someone who's covering on night call or the weekend, and that may be you, and you can look and say, oh, Dr. Cullinan says it's fine to do this. Or you might see one of my patients that says, no, under any circumstances, or no, contact Brolio. And this is why you have my cell phone and text, because there are certain patients that I may say absolutely not, such as people with stable disease, cancer survivors, high risk for opioid misuse, people that run out of prescriptions early. Urine drug screening, you'll put the date and you will put the pertinent findings. I can put as expected, and the date done. PDMP reviewed, again, it needs to be reviewed every visit, and the secretary will send that to you by email the day before the visit. Morphine equivalent daily dose, you want to calculate and update each visit. And then the pill count, great. It may not even be necessary because it's not applicable if you're mostly doing telehealth. Now, there is also a buprenorphine management template, but this is not if we're prescribing things like the Butrans or the Belbuca, which are low-dose buprenorphine products that are FDA approved for pain. This is when I'm managing buprenorphine and with my X waiver, and I may be treating pain, but this is in someone who has opioid misuse or opioid use disorder. So if you're using your X waiver, which hopefully all of you will have soon, then this is the one that you would use. You want to make sure you complete a treatment agreement. If you're seeing this patient by telehealth, you can review it with them and tell them that you will send it in the mail. They can sign it and send it back, and then you will sign it and it will get scanned and put in the medical record. If they're in clinic, the nurse will actually prepare it for you, because you'll see in the morning when we talk about what's needed outpatient, I may say, so-and-so is coming in and I need a treatment agreement. I'm going to order a urinary drug screen, and I will need an EKG done. And so this is what would happen in this case. And they get scanned and put in the medical record, and we should be renewing them yearly. And then you're going to order your urine drug screen, especially if it's your first time. The one that we mostly like to use is the Lab 4093. You would order it, and then you would click Clinic Collect if they're coming to 5B. If the person is seen in 3K, which is where the infusion suites are for oncology patients, and they get their labs before they see their oncologist, you can indicate lab, and they can also be collected down there. If this is someone seen in telehealth, but you really want to have a urinary drug screen done, you can basically have it sent to an external lab. You just have to find out which one, and then have the nurse fax the order over. You always want to put yes for confirmation, and this is so that you get your gas chromatography mass spectrography. Because you'll learn, I think you probably have a session on interpreting urine drug screens, and you know that in your rapid you may see opioids, but you don't know what opioid. Now, our urine drug screens rapids does say oxycodone for the urine, and it has methadone, which is the methadone metabolite. It does show fentanyl. It does show buprenorphine, but methadone, it's actually looking at the metabolites. So if you see it on a rapid, that's a positive. With the other ones, it could be a false positive, which is why you need to wait for the confirmatory results. At this point, they're being sent out to Mayo, and so it's taking about a week for turnaround. You want to then associate the diagnosis. You don't want to put cancer. You don't want to put, hypertension. You want to put the real reason, and which is F11.9. And then you have this whole drop-down list. If this is someone who's using opioids therapeutically, then it's chronic continuous use of opioids. If there are other challenges, with like uncomplicated opioid use or opioid misuse, then you would click on those. And this is where you click it in, and then you set the order. So I'm going to take you through a few tips about ordering controlled substances in the medical record, because I don't know how many of you have really worked in clinic and have ordered outpatient, but we'll go through it. You're going to go to plan, and you'll see the medication management drops down, and if it's a medication that needs renewed, you can just click on that, and you see that little half circle and click on that, and it'll click on reorder. But say this is a new medication you need to order. In the bottom left corner, you'll see add order, and you go to add order for a new prescription, and I'm going to type in morphine. And then what's going to come up is a list of different morphine formulations. But say you do not see the formulation that you want here. Then you're going to click facility list, and that will bring up a longer list. And then this is what comes up. And then it's going to ask you about if it's a palliative care or cancer patient. I say yes. And this is cancer-associated pain. But say this is someone with pulmonary artery hypertension that I'm treating with opioids because of the pain secondary to his infusions, then I would put palliative care patient. And then you want to make sure you fill in the other parts of this document in terms of the many tabs you need. Obviously, there's going to be no refills unless it's a buprenorphine product because it's a Schedule 3. But you would check with your supervising clinician to see if you would put refills. And then you would choose your pharmacy. But you want to make sure that the correct pharmacy is listed. In this case, there's no pharmacy listed. So I'm going to click on the pharmacy, put in the name of a pharmacy that I want, and it'll come up. And if this is one that they use all the time, I would star it. And so then I would go ahead and accept that. I would sign the order, and then you'll see there's a 2-step authentication process that will have you put in your password. It'll be password number 1 and password number 2. You may have already set this up, but if you haven't, I have my password number 1, and I make my password number 2 the backwards of number 1 to remember it. And then you'll need to either use your token or your RSA code that is on your secure ID that's on your smart device. So some extra tips for prescribing. You want to document carefully under your plan. You want so that whoever opens this up, whether it's the weekend or night, knows what your plan is and knows what they should do. So you want to complete the treatment agreement, UDS if applicable. You want to put the medication, the dose, the route, the number prescribed. And if higher risk, you'll see on some of my notes, it'll say 2 last through 7/25 or 2 last through X date, And you want to make sure that patient has a nasal naloxone prescription if they're on a morphine equivalent daily dose of greater than 100 milligrams, although the CDC recommends greater than 50 milligrams. So this was a quick run through that you may not remember any of it by the time you get to clinic, but you'll have this as a resource. And obviously you can ask your palliative outpatient clinic or contact me if you have questions.